Hi all, so today we're going to talk about using point-of-care ultrasound for screening for small bowel obstruction. So you're working in the emergency department, it's really busy, CT is backed up, and you have a 52-year-old female who comes in with sudden onset vomiting, diffuse abdominal pain. She's writhing around on the stretcher, she's obviously in a lot of pain, and she is just profusely vomiting everywhere. She does have significant past medical history. She's had an appendectomy. She's had removal of a right ovarian teratoma. And so what's your differential diagnosis and what's your plan? So do you go ahead and just put in for a CT and wait for that? Do you get a acute abdominal series, or can you maybe use ultrasound as a screening tool? So this just gives a little bit of background on the likelihood ratios of imaging for detection of a small bowel obstruction. You have your abdominal x-ray, your CT scan, which is obviously what we use and the best for really diagnosing the bowel obstruction and your transition point, and then point of care ultrasound. So this is a Class C or rating C evidence for utilizing point of care ultrasound for bowel obstruction. We tend to use it more as a screening tool, so I'm not necessarily looking for the transition point. I'm looking and utilizing it as a screening tool to see if this patient might have an SBO. Do I need to think about dropping an NG tube, or is there something else potentially going on and it's likely not a bowel obstruction or a pretty severe ileus? So how do we do this? Well, first you have the patient lie flat on their back, you wheel the ultrasound machine into their room, and then you use the curvilinear probe. And so I don't have a really good picture of it right here, but the curvilinear probe, it's not the phased array that looks like a little square that we use for the heart. It's not the linear because that's a high frequency probe and really only good for superficial structures. So this is that nice rounded one. It's a pretty big probe, but it's really the best for this exam. So then I start by just screening. I want to look in the patient's right side, their left side, in the suprapubic region. I want to look in the epigastric region, and I'm just doing a quick view, see if I see anything right off the bat. And then I go back and I lawnmower. So I start in the transverse plane, right lower quadrant at their right hip, and I just zigzag all across their abdomen looking for a small bowel obstruction. When I'm documenting this, I focus on my area of where I'm seeing the pathology, if I'm seeing pathology. Otherwise, I tend to get a picture of the right lower quadrant, right upper quadrant, left upper quadrant, and left lower quadrant. If I'm seeing something, then I'm getting a lot more videos and images around that area. And remember, this lecture is only focusing on small bowel obstruction. When it comes to some more pediatric related bowel ultrasound, appendicitis, intussusception, pyloric stenosis, that's a different lecture for a different time. But first I'm looking, and we're seeing some normal bowel right here. So if you look around the mid to right side of the screen, we're seeing bowel lumen. We are seeing just nice peristalsis. That bowel is just peristalsing and moving and pushing that content onward, and that's a very unexciting, that's normal bowel. So nothing really exciting to see here. That's just normal bowel. Kind of looks like just gray waves like smushing around in the middle of the screen. Then we come to a bowel obstruction. So the first thing that we're going to see when we are looking at a bowel obstruction is a dilated loop of bowel greater than 2.5 centimeters. So I'm looking from outer wall to outer wall and measuring, and I'm seeing that this does in fact measure more than 2.5 centimeters. So already I'm pretty concerned for a bowel obstruction. Then I want to look at the contents of the bowel. So am I seeing true peristalsis and the bowel contents are actually being pushed forward? Not in a bowel obstruction. So we're going to see to and fro movement of the bowel contents. So we're looking and we're seeing this bowel is fluid filled, so that's going to look darker or black on ultrasound. And then we're seeing just the white little particles of air, food, bowel contents going back and forth, back and forth. So that's what we call to and fro movement, or to and fro peristalsis, and that's another sign of bowel obstruction. Then we look for the keyboard sign. So if you remember back to Netter's gross anatomy, we are seeing that plique circularis that will be present in our small bowel. And on ultrasound, because you have your bowel lumen is just full, now that's going to allow the ultrasound beam to come in and penetrate, and you're going to see the plicae circularis projecting into the center of the lumen like a keyboard. So you can see it a little bit better right here. If you look closely, there we go. You're seeing the plicae circularis. Those are projecting into the lumen. It looks like fingers reaching into the lumen or a keyboard. So now what are we seeing right here? If you look closely, this is just going to play for a minute. So I don't have any measurements on this. I don't have any clips. It looks like it could very well be dilated, but we are looking in the middle of that bowel lumen. We're seeing not a whole lot of peristalsis. Actually, there's really no peristalsis that I'm seeing here. You can say that maybe you see some to and fro movement of the contents, but that just really isn't doing a whole lot. But we're definitely seeing those plicae circularis projecting into the center of the lumen, making me more concerned for bowel obstruction. What about right here? Look closely at this one. So we are seeing some hand movement of the ultrasound probe, so from the outside just sweeping through, but on the top of the screen we're seeing a nice dilated loop of bowel. Although it's not measured, we can come over to the sidebar where we have the measurements here, and every long dash is a centimeter. So if you're looking closely, that looks like it's at least 2.5, 3 centimeters using the measurement tool on the side of the screen to help measure. We're seeing some plicae circularis going into the lumen. We're actually below seeing another dilated loop of bowel up underneath as well, and we're not seeing a whole lot of movement of the bowel contents. So immediately your suspicion for a bowel obstruction has been raised. So now a late finding for small bowel obstruction is decreased or absent peristalsis. So if you look closely at this ultrasound machine, you're looking at the top of the screen, and you are seeing just a bowel filled with luminal contents, which is not moving much at all. So we're seeing just decreased or totally absent peristalsis in this case. So that's concerning that this isn't more acute and that this may be a little bit later. Just another view of a small bowel obstruction. So we're seeing nice dilated loops of bowel right here, and we're actually starting to see what looks like some free fluid coming in between these loops of bowel. And free fluid in the abdominal cavity on ultrasound is going to have sharp borders. So immediately we're a little bit more concerned that maybe there's some fluid coming out. And so we actually have a name for that. It's called the Tanga sign. And so if we're having a bowel obstruction here, so it's a late finding of bowel obstruction, but we're seeing free fluid in between the loops of bowel. And so we're seeing that free fluid. We're seeing these nice dilated loops of bowel. We're not seeing any peristalsis. At this point, we're not even seeing really good to and fro activity. We're just not seeing much at all. So I'm really concerned in this patient for bowel obstruction. Another thing, if you wanted to, would be to measure the bowel wall thickness. So the bowel wall thickness should be less than 3 millimeters. And although it's not in here and it's not something that we normally get, but that would be more concerning as well. So that in a nutshell is how to do ultrasound as a screening for small bowel obstruction. So in this case, let's say your CT is backed up, you're seeing clinical signs of small bowel obstruction, you're concerned about it, you do an ultrasound and you're like, yeah, this patient has a bowel obstruction. I know I need to get a CT. We're going to look for that transition point on CT, but immediately maybe I can go ahead, place my NG tube, consult general surgery, and have everything ready to go. Make sure I'm treating the patient's pain. Please email me if you have any questions.